Let's go on to Mack. How do we define anesthetic potency? A broader question. When I say potency, we're doing a Rorschach. What do you think? What do you think? Potency?
What do I think about it?
Well, what word pops in your mind?
Mack value.
Mack value pops in your mind. What else pops in your mind? What are other indices? Okay, so reasons why you get potency pop into your mind as well. But are there other Macks in this life besides Mack itself? What are the other Macks? Big Mac and what else?
Mack bar.
There's Mack bar. What's Mack bar?
It's the blending of the adrenergic response.
Right. So it's the minimum alveolar concentration that blocks the adrenergic or autonomic response, that concentration. What else?
Mack awake.
There is Mack awake. Okay, what's Mack awake?
Mack awake is the minimum alveolar concentration at which 50% of patients will respond to command.
Right. Appropriately. Appropriately. We'll see an example of that in a little bit. Why do we choose 50% rather than 90% or 95%? Why?
Because Mack value slightly above that will affect primarily 95 to 100% of the patients.
So Mack 50 tells you what Mack 90 is. It's very close to Mack 90. But is there an experimental reason why we don't use Mack 90 or Mack 95? Yeah.
My answer to the previous question was I thought this would make an easier experimental model actually when they were designing the original studies to determine what Mack was. When they would actually, choose if someone responded or did not respond, that's kind of a 1 and 2 response. They could continually do that and figure out the 50% value the easiest.
That's the answer. That's really the answer. That the 50% response is almost always the easiest response to determine with the least number of experimental subjects. And then when you combine it with the fact that it really does tell you where the 90% is within a few percent of the Mack value itself, that makes the determination at 50% the really logical one to do. That is, if you take the percent responding and you increase your anesthetic concentration, remember Mack is the 50%, and this is 100% up here. We go along, and then suddenly it goes down like this. Over here, you get a lot of variability. Variability is very great. But right here, the variability is very small, which makes the numbers that you have to acquire in order to define this point much smaller. In fact, you might have to give anesthesia to 10 times as many patients to get the ED95, to find the 1 in 10 or 1 in 20 who does or doesn't respond than you do at the 50% point. So that's why you choose 50 rather than 90 or 95. There's the definition of Mack, and it is, as we said. What part of the central nervous system mediates this capacity of inhaled anesthetics to produce immobility? Which one? We got a lady who hasn't answered many questions here.
The spinal cord.
The spinal cord. It isn't the brain. It isn't the brain. We used to think it was the brain. When I went into anesthesia 250 years ago, we thought the brain controlled everything. Well, it isn't. The spinal cord is the part of the central nervous system that produces Mack or mediates Mack. How do we know that? How do we know it's a spinal cord?
If you sever the connection between the brain and the spinal cord, it doesn't alter the Mack.
That's the answer. There's another answer as well, but that's the one that Ira Rampel proposed. Joe Antonini proposed another experimental model and used it to show that it was, again, the spinal cord rather than the brain. Does anyone know what Antonini did? Michael, what did Antonini?
Was it the model with the sheep where they have a vertebral flow that goes to the spinal cord but not to the cord?
You're onto it. You're onto it. Quinn's going to help you.
It was a selective perfusion studies in goats where they could cannulate the carotid arteries, and that only perfused the brain, and then they would use the rest of the systemic circulation to perfuse the spinal cord.
Right. What did they find?
Well, they found that to abolish movement by administering the anesthetic to the cerebral circulation, you had to deliver a significantly higher concentration than you did for the systemic or the
Yeah.
spinal cord circulation.
How much higher?
I'm guessing, but I think it's 5 or 6 times.
In some experiments, it was that much higher. In the initial experiments they did, it was about 3 times higher. And in some cases, they could never get immobility by perfusing the brain, no matter what concentration they used. This is an illustration from Rampel's work showing the 2 places that Rampel cut the connection between higher centers over here in a rat and lower centers over here. There's one section, and here is the second section. And then, as was said, what Rampel found was that when you severed the connection, you made the animal decerebrate. Over the passage of time after decerebration, there was no change, and this didn't differ from a control animal in which the severing was not accomplished. So this was an animal in whom there was a sham operation done, but no severing of the higher centers from the lower centers. So that pretty well proves that the spinal cord is the primary mediator of the capacity of inhaled anesthetics to produce immobility. What about intravenous anesthetics, such as propofol? Does that work on the cord?
They found that works both on the brain and the cord, I felt.
And the cord effect is minimal. So it's only a really slight effect on the cord. It's almost all the brain. So propofol causes immobility. Yeah, you can give a propofol anesthetic, but it's because propofol is doing something to the brain. And we may even talk about that a little bit when we talk about mechanisms of anesthesia. How do we determine Mack in an animal? How are we going to do that?
I think you're looking at movement versus non-movement. So what we were talking about before, you're getting 50% with movement, 50% with non-movement. You're looking at the amounts of anesthetic that are delivered, and then you get a crossover between the two.
What do you mean by amounts of anesthetic that are delivered?
Concentration.
Concentration.
Concentration where?
Yeah, alveolus.
In the, say it louder,
In
or
the
more
alveolus.
loudly. Again,
The alveolus.
what does Mack stand
Alveoli.
for?
That's the alveolar concentration at which
Right.
you see 50%.
It's the minimum
Non-movement.
alveolar. Why the alveolar concentration? Why
Well,
not the inspired? Why not the vaporizer?
Well, that's going to most accurately reflect the brain concentration or the spinal cord concentration
Exactly
in
so.
this case.
Exactly so. What do you have to do to ensure that it's reflecting the spinal cord concentration?
Well, you have to wait till they've equalized. You
Yeah,
can't just
right.
start at the beginning
That's
and
all.
apply your
That's,
stimulus.
you give them the answer. You can stop now. Right. So you've got to allow for equilibration between the alveoli and the spinal cord. And once you do, you have a direct measure of the partial pressure of the anesthetic at whatever its site of action is. How long does that equilibration take?
Depends on the agent you're using.
It does depend. That's right. But if you said overall for the commonly inhaled anesthetics, how long would it be?
30 minutes.
30 minutes would be more than enough time. And what's usually allowed is 10 to 15 minutes. That's several time constants. We'll get to time constants in just a minute. So you anesthetize the animal at a concentration which permits movement and then at a concentration which prevents movement. That is, you bracket the concentration which might or might not permit movement. So if we were to anesthetize an animal with sevoflurane and hold the end-tidal concentration at 2.1%, pinch the animal's tail, find no movement, we would go down perhaps to 1.9%. We'd then allow equilibration to occur again, we'd stimulate the tail, and this time when we stimulated the tail we found movement. We'd say that Mack lay halfway between these two concentrations. Now the problem that we get to in humans is that humans don't have tails. So how do we deal with that? How do we do it in humans, which are really the animal of concern? Yes, how do we do it in humans?
Tetanic stimulus or?
We could use a tetanic stimulus, and that has been done. But what would you prefer?
Skin incision.
Say it loudly.
Skin incision.
Loudly!
Skin incision.
All right, that's right. We get our surgical colleagues to help us. But again, we only get one cut. So how are you going to deal with that? You need two cuts. You're going to ask the surgeon to make a cut and then wait and then make a further cut? Well, he has to or she has to wait for 30 minutes while you change the concentration? No, you're not going to do that, are you? So what are you going to do?
I don't know.
Okay. Anyone have a suggestion what you're going to do? How are you going to manage it?
You have to determine the point at which one patient will move in response to surgical incision and figure out what the concentration is, and then the next patient, you figure out the concentration, and you keep going somewhere in between until you get to 50%.
So you use 2 patients instead of 1. I think that's what you were saying, isn't it?
Right.
So if the first patient moves at a concentration of 1.1% isoflurane, in the second patient you'll go up because this patient moved. And you keep on going up until you get no movement. And the bracketing concentrations, the one that permits movement and the one that prevents movement, are the ones that define Mack for that pair. And you gather 4 to 6 pairs of patients using that technique, which is called the Dixon up and down technique. And that defines Mack for inhaled anesthetics in humans. Now we're going to show you a demonstration of Mack, or a demonstration of the determination of Mack, using the tetanic stimulation. Remember that we're watching the patient, or someone else is watching the patient while we're doing this.
Mike, we had a very cooperative child this morning. And tell us what we tried to accomplish.
Well, we actually saw a couple very interesting things. As we noted, the child was calm coming out, very cooperative getting back onto the OR table.
No pre-medication.
No pre-medication whatsoever. The child actually held the mask up to his face, helped us to start his own induction. We turned the Sevoflurane on.
Then gave him a painful stimulus on the right arm. And what did you notice at that point?
Again, he had some purposeful movement, which again is consistent with those low levels of Mack.
That's right. And then we deepened the anesthetic. And again, what happened when we stimulated his arm?
Again, we still had given no additional rocuronium, so we know that the muscle relaxant wasn't in play there, and we saw no spontaneous movement.
And that's a reasonable demonstration of Mack in one patient. So at 1.5%, tetanic stimulus, and then the child moved after that. And then at 2.5% with tetanic stimulation, although the response to the tetany was there was no subsequent movement of the hand. So the Mack in that patient, we might say, would be about 2%. That's about what Mack is for sevoflurane. Now here are the resulting values from determinations of Mack in humans. If you talk about the Mack values in oxygen, they range from a low of 0.75% for halothane to a high of 105%. That's of what? 105% of what? Can you give 105%? Well, you can. Of what, though? Oh, you can say it loudly.
Hyperbaric chamber.
In a hyperbaric chamber. So it's 105% of 1 atmosphere. Of 1 atmosphere. Now, clearly, you can't give 105% of nitrous oxide unless you're willing to go down to Death Valley. Well, never mind. And that is anesthetic for nitrous oxide. Now, notice that this is for 30 to 60-year-old subjects. And we're going to talk about age, but if we had a different age, the values would be different. And notice that nitrous oxide itself adds to the effect of halothane, isoflurane, sevoflurane, and desflurane. So it reduces the Mack, and does so roughly by 1% for each percent nitrous oxide. So nitrous oxide produces a halving at 50 to 60% nitrous oxide of the Mack for desflurane at this age. At this age. At different ages, it will differ, and we'll see that in a moment. Before we look at what factors change Mack, let me ask you what factors don't change Mack. What physiological factors don't change Mack? Name one.
Gender.
Gender doesn't change it. So it doesn't matter whether you're a male or a female. What else?
Duration of anesthetic.
Duration of anesthesia doesn't. Anything else? What else? What else?
Body mass?
Body mass. Sure. If you're fat or thin, you got the same Mack. Tall or short, you got the same Mack. You're a dwarf, Same Mack, same Mack. In fact, across species, the Mack doesn't change very much. Doesn't change very much. So here's an extension of that list. As long as you keep physiological factors reasonably normal, there's no change in Mack. Arterial PaCO2 above 50 millimeters of mercury, or PCO2 less than 80 millimeters of mercury, or hematocrit that's greater than 10%, allows you to get down pretty low without changing Mack. Blood pressure above 50 millimeters of mercury doesn't change Mack. And here's one example of that, the example of duration. This was in some studies that we did in rats anesthetized with desfrane, but the same thing is true for the other inhaled anesthetics. So the Mack was here at the start of anesthesia, and then 5 hours later, it's the same place, same place. No change, no change. So increasing duration doesn't affect anesthetic requirement. What are the physiological factors that do change Mack?
Age.
Age. How does it change Mack? Which way?
It decreases your Mack as you increase in age.
As you increase in age. What else?
Temperature.
Temperature. Tell me more about it.
The lower your body temperature is, the less Mack it requires for the person to stay anesthetized.
Right. Now we said gender doesn't affect Mack. Is that true under all circumstances?
Pregnancy lowers Mack.
Pregnancy lowers Mack. The other factor is decreased central nervous system sodium will decrease Mack, so our increased. How can we get a change in central nervous system sodium? How could you get a change? What might you do? Under what clinical circumstances could this happen? Say it louder, James.
Dehydration.
Dehydration, right. What else?
SIADH,
I don't know what that is.
syndrome of inappropriate antidiuretic hormone.
Right. Yes, you definitely could alter sodium.
Cerebral salt wasting syndrome.
Okay, that would seem to do it. What do we do that might do it? How many of you have given anesthesia for a patient having a transurethral resection of the prostate? How many? What happens during that might alter the sodium in the body? What else?
The irrigation fluid that they use when they're actually looking at the prostate with the scope, and then they are bovying out the prostate, some of that can be absorbed by the venous sinusoids.
Yes.
And make the sodium go down.
And make the sodium go down. That's right. How can we make the sodium go up? How many of you have done intracranial operations in which the surgeon has asked you to make the brain more slack? We've got one right there. How did you do it? How did you make the brain more slack?
A couple ways, but one was infusing mannitol.
And what would that do?
It's osmotic diuretic, so we, by doing so, we withdrew water from the brain parenchyma into the blood volume.
And what would that do to central nervous system sodium?
Would decrease it.
Decrease it or increase it? If you take water away, what does it do to the sodium?
Would increase
Would
sodium
increase the
concentration.
sodium, yeah. And in fact, that's one of the experimental ways we have increased sodium and shown the increase in Mack that results. This is the example of age and its effect on sevoflurane Mack. So we see the progressive decrease. Notice this is the log scale here. This is the sevoflurane Mack, and a progressive decrease in the Mack of sevoflurane. Each one of these is a separate full study with 4 to 6 or more more crossings for sevoflurane. So you see a lot of studies that were done showing the progressive decrease. And notice the steeper decrease for sevoflurane in 60% nitrous oxide. That is, 60% nitrous oxide becomes itself a greater and greater fraction of Mack as age increases. So the same concentration of nitrous oxide adds much more to the anesthetic effect of an older patient than it does to the effect of a younger patient. Here's the effect of a change in body temperature, producing, as was suggested, a decrease in Mack with decreasing body temperature. A halving of Mack for a 10-degree decrease in body temperature. Now, there are many pharmacologic compounds that will affect Mack. We already had one suggestion that alcohol will affect Mack. How will it affect Mack? If you drink?
you can differentiate between acute and chronic alcohol.
Right. And what's the differentiation between acute and chronic?
Well, chronic alcohol will require more Mack.
So you will increase Mack with chronic alcohol. As long as you're not drinking at the moment,
Right.
the Mack is determined. And it will do the converse in the patient who is acutely drunk. All right. What else will affect Mack pharmacologically? Yes.
Use of opioids.
Use of opioids, which we do every day. We make use of that interaction to decrease Mack. And is that a synergistic or an additive effect?
I believe it's an additive.
Would everyone agree with that?
Obviously.
You had a 50-50 chance there. Okay. And indeed is synergistic, and we'll show that in just a minute. Anything else? Yes.
Benzodiazepines?
Benzodiazepines will decrease Mack. And do so how much? A little bit or a lot?
A lot.
A lot. Well, obviously it's dose dependent, isn't it? Dose dependent.
Absolutely.
Can you achieve anesthesia with a benzodiazepine by itself?
Yes.
It's very hard. You have to give enormous doses. And even then, many animals will move in response to stimulation. So you might be able to, but I think it would be very difficult. It would be very difficult. Okay, let's see a list of the depressant drugs that will decrease Mack. And it's what you would expect. And we have noted the opioids, the benzodiazepines, the barbiturates, and of course propofol. Local anesthetics, not because they produce local anesthesia, but if you give them intravenously, you give a lidocaine intravenously, it will decrease anesthetic requirement as defined by Mack. And of course nitrous oxide will decrease the requirement for potent inhaled anesthetics. Now here's a demonstration of the synergistic effect of fentanyl on sevoflurane Mack. So this is the sevoflurane concentration that is Mack, and this is without any fentanyl. So here are the patients who moved in response to surgical stimulation. The the blue dots and the open squares are the ones who failed to move. And the point of this slide is to show you that as we increase the serum fluoride levels, we never reach Mack, but there is an acute response at these lower concentrations, which almost equal the responses at much higher concentrations, suggesting the synergistic interaction between opioids and anesthetic requirements. So just that little dose of fentanyl that we give as part of the induction considerably alters anesthetic requirement as defined by Mack. Now we have an OR scene which documents some of this. We had a patient who was at about 3/4 of a Mack, but with no fentanyl. And today we've given this patient what?
2 mics per kilo of fentanyl.
And we're at the same concentration of sevoflurane.
We are.
And now the question is, will this patient, unlike the previous one, not respond? What are you going to do here?
Well, we're going to simulate surgical incision by tetanus and see if this patient has any spontaneous and purposeful movements.
Tell us when you're going to do the tetanus.
Okay, the tetanus is coming, and now. And we notice that there is no purposeful movement.
Okay.
Which is consistent with what we would expect. We know that fentanyl or narcotics in general decrease our Mack values.
And do so synergistically, don't they?
Yes, they do.
Okay, it's a good illustration of that. We see how fentanyl interacts synergistically to decrease the Mack. We saw that in the slide, and we saw that in the illustration in the operating scene. I want to remind you all that in the operating room, while we're talking, someone is, in fact, watching the patient. Now, there are many drugs that we've already suggested that will decrease Mack. Those are pretty obvious drugs, like fentanyl or like midazolam. But there are some that are less obvious. And in fact, you had a question about that.
Dr. Eager, and considering the definition of Mack, other drugs that aren't listed are things like muscle relaxants. Do those affect Mack?
That's a good question. And you would think about that in terms of the definition of Mack. Because the definition of Mack says what?
That 50% of the patients will not move to a noxious stimulus.
And if you gave a muscle relaxant, what would that do?
That would seemingly lower the Mack because no one would move.
Right. So the Mack definition really has to include that this is a central nervous system phenomenon and not a phenomenon of paralysis. And in fact, it does, although that's an unstated part of the definition. But still, The question is there a central nervous system effect of muscle relaxants that decreases Mack? After all, what are muscle relaxants? What do they do? What do these neuromuscular blocking drugs do to produce blockade of impulses?
Well, they prevent the transmission of the motor input potential at the postsynaptic junction by inhibiting acetylcholine receptors or blocking acetylcholine receptors.
Right, so they block the receptors. They block them from the effect of acetylcholine. And acetylcholine is a central nervous system transmitter too, isn't it?
Yes, sir.
So you might think, well, if the muscle relaxants got into the central nervous system, maybe they would decrease Mack. Maybe they would. That'd be an interesting thought, wouldn't it? And in fact, we know that if you give muscle relaxants directly on the brain, like galamine, a muscle relaxant that we don't use anymore, it causes convulsions. So it can cause potent effects on the brain. Now, there are data that suggest that muscle relaxants do not affect Mack, and there is one study which suggests that it does. How would they ever study that?
I'm not sure.
Because you'd have to retain motor movement in the face of muscle relaxants getting to the brain of humans. How would you do it? What would you do to maintain the ability to move and yet get the muscle relaxant in the brain? Oh, I got a lot of hands here. All right, go ahead, tell us.
A blood pressure cuff or tourniquet, like they use in ECT, where you can put in some motor, you can put in the blocker, but you essentially block it to one portion of the body.
Exactly. So you isolate one extremity from the circulation, and that's what they did. And they found in one case that they did show a smallish decrease in Mack, but in all the rest of the cases they did not. You would expect that there should be, in fact, no effect of muscle relaxants on the brain. Why is that? What is the characteristic of muscle relaxants that separates them from all the other drugs that we use in anesthesia?
They don't usually cross the blood-brain barrier.
Why?
They're usually polar agents.
That's right. They're all ionized. So they can't get into the brain. So you would expect there to be no effect. Now, there are many other drugs that act on receptors that might affect Mack. Name some of those. What other drugs might affect Mack?
Clonidine.
Clonidine. Or what's the other drug that's been released?
Dexmedetomidine.
Dexmedetomidine. Dexmedetomidine. What does it do to anesthetic requirement?
It decreases Mack.
Decreases Mack. It can decrease it to zero. That is, the dexmedetomidine can be an anesthetic itself. Anything else? Well, there are a whole list of these drugs. So the alpha-2 sympathetic agonists like clonidine and dexmedetomidine, some beta blockers, but not all of them. Calcium channel blockers, adenosine, and ATP, and false neurotransmitters can all influence Mack. So we see here the effects of dexmedetomidine in the study by Vickery, published many, many years ago. And L-medetomidine has no effect. It's only the dextromedetomidine that causes the decrease in anesthetic requirement. Let's go on to what we call Mack awake. We already have had the definition of Mack awake, which is the end-tidal concentration that suppresses appropriate response to command in 50% of subjects. Why is Mack awake important? What does it define?
Because usually the Mack awake exceeds the Mack for amnesia. So hopefully if you're at Mack awake, hopefully you have amnesia at that point.
Exactly so. So it's a concentration that almost assures you of suppression of remembrance. Maybe not of all forms, but at least of most forms of remembrance. It's also a determinant of anesthetic recovery, isn't it? At Mack, patient's responding. So you would say that the patient is awake. And there's an element of safety to this because an awake patient is more likely to maintain their airway. But it's not a complete assurance of safety. This is a slide showing the potential for regurgitation at concentrations that are in fact less than Mack. So this is 25% of Mack. There's an increased potential for regurgitation that is a relaxation of the upper esophageal sphincter. 50%, it's even greater. And that's true of all the inhaled anesthetics. So the quicker we can get down below Mack awake, and well below Mack awake, the better. We also know that Mack awake is affected by at least some of the same factors that affect Mack itself. So age affects Mack awake. As you get older, your Mack awake goes down. We know that Mack awake can vary among anesthetics, and this is an important aspect of Mack awake relative to Mack. And Rory Dwyer and I studied this in some volunteers, determining what concentration volunteers responded appropriately to command with isoflurane, and on a separate occasion in the same volunteers, what concentration suppressed response to command with nitrous oxide, and finding that as a multiple of Mack, there was a difference between the two, with nitrous oxide having a much higher Mack awake value, above 60% of Mack, than isoflurane, which had a Mack awake value somewhere around 30 to 40% of Mack. What does this imply to you? What does it mean? Why is it important? Does anyone care? Try it, Michael.
Well, it would help in recovery time. So, you know, if you could recover somebody more quickly, you could get them through the PACU a little bit more quickly.
So which anesthetic would you choose?
In that case, I would choose nitrous oxide.
Right. And it's one of the reasons why nitrous oxide continues to be so important. It, more than the potent inhaled anesthetics, allows recovery to occur quickly. Yes.
But in that situation, you're saying that Mack awake is around a little over 60%.
Of Mack.
Correct. With the Mack of nitrous oxide being 105.
Right.
So if you give, at best, 70% nitrous, you don't have a very large window there between Mack awake and the maximum amount you can deliver.
So what do you have to do?
You have to supplement in some other way.
You have to supplement it. But that contribution of nitrous oxide still remains less of a factor in terms of awakening than does what you use to supplement it with, which might be propofol, or might be desflurane, or sevoflurane, or isoflurane. So the use of the nitrous oxide helps you in the rapidity of awakening. What's the downside of it? What's the downside of it? You, in fact, gave that answer already, didn't you? The Mack awake of nitrous oxide is very high, which means that it's what? Not a very good
amnestic.
Not a very good amnestic agent. So you have to give anesthetic to supplement it, not only because you don't want the patient to move, but because with 70% nitrous oxide, patients remember. It isn't sufficient in itself to suppress awareness.